larger share of the risk, and then gradually as both the state and the contractors get a better ability to predict future costs, then more of the risk would shift to the contractor. So what are some of the risks and opportunities in managed long-term care? The major risk, or a major risk, is that the contractor may stint on needed care, may not provide the needed care in order to end up with a higher margin or a higher profit. Contractors may not fully understand the Medicaid population and its needs. That was a common problem back in the mid-1990s when a lot of states moved to managed care for the moms and kids population. Not a problem now. There are a lot of companies with a lot of experience in that area for moms and kids and for acute care services. Still a problem for long-term care services like home and community-based service waiver services and institutional services. There are fewer organizations that have a lot of experience providing those kinds of services for the Medicaid population, or for any populations for that matter. And there's also the risk that the contractor may not have the needed experience in all of the financing and operational kinds of things that a managed care organization has to do. They got to establish provider networks and payment systems and ways of communicating with enrollees and handling complaints and grievances and all of that. It's a major complicated business, and the managed care companies that do that in Michigan for the acute care population have gotten good at it. And they have a lot of competition, so they have to be good at it. But again, it's a pretty complicated and sophisticated business to be in. Some of the major opportunities, having a single entity at risk for both the nursing facility and the community services can facilitate shifts back and forth, take savings from lower use of nursing home services and use those to expand community services. The managed care organization can help to coordinate care for disabled and elderly beneficiaries with complex care needs, may not necessarily have the help from families that they need. They may have mental health or other kind of cognitive disabilities that are an impediment. And expanding that risk to include acute care, hospitals, physicians, etc., can further enhance these care coordination opportunities, and including Medicare services for those who are dually eligible for Medicare and Medicaid is yet another way of coordinating an important piece of services for these beneficiaries, and I'll come back to that in a minute or two. Some of the managed care program design issues that I know Mike Head and his staff are struggling with are and going back and forth on are, who should be covered, elderly, under 65, disabled, both, mandatory or voluntary. Some states have the initial assignment be essentially a mandatory assignment, but allow people to opt out into some other setting, fee for service or otherwise, quite easily. Which services should be covered? Just long-term care services or some acute care services as well? What kinds of entities ought to be eligible to serve as a managed care organization? Should you start statewide or start in some pilot areas? How many managed care organizations per area? You can't have too many because then it divides up the available population and none of them gets a critical mass of enrollment. But CMS usually does require more than one if there's any form of mandatory enrollment. The bullet at the bottom gives a link to a document that provides more information on some of those kinds of design issues. Some of them, there are models from other states. There are about 7 states that have managed long-term care and have had it for varying periods of time. There's a good AARP issue brief from a couple years ago that provides very valuable detail on those programs. Just a few highlights from that. All of the programs, except for Florida and Massachusetts, cover both the elderly and the disabled. All the programs except Wisconsin and New York cover both acute and long-term care services. They're all voluntary except Arizona, Texas, and Wisconsin. And only Arizona and Massachusetts are statewide. Arizona is the longest standing managed long-term care program. They've been going since like 1983 or 85 or thereabouts. Some of the lessons from other states, program design and implementation takes time, and you really do need to spend that time consulting with providers and beneficiary advocates and other stakeholders. You shouldn't expect to see savings from these programs right away. People have lots of accumulated unmet needs that need to be addressed, and it takes time to change the settings in which care is provided and the ways in which care is provided. So institutional use doesn't drop immediately. Hospital use doesn't drop immediately. Use of prescription drugs doesn't instantly become more cost effective. So it does take time. There's likely to be resistance from existing long-term care providers. Nursing facilities, for example, part of the goal of the exercise is to reduce use of nursing facilities, and they may not necessarily welcome that. And there's likely to be opposition from organized beneficiary advocacy groups. Many of the people in these groups are in fact managing their own care, taking a lot of effort and a lot of time to do it, but they've developed effective ways of managing their own care, and they're frankly doing it better than probably most managed care organizations could do on their behalf. Those are the people you are likely to hear from in the legislature, but those who would benefit most from better management of their care, people with low education levels, relatively limited links to the community, various sorts of cognitive impairments, and very, very, very complex care needs, they're the ones who benefit most potentially, and they're the ones you are least likely to hear from. Just a very brief word about some longer-term opportunities to manage both Medicare and Medicaid services. Almost all elderly Medicaid beneficiaries are also enrolled in Medicare, and about 1/3 of the disabled beneficiaries in Michigan and other states are enrolled in both Medicare and Medicaid. They're called dual eligibles. There are about 134,000 elderly duals in Michigan and about 89,000 disabled duals. And with this population, states can contract with what are called special needs plans. These are Medicare plans, cover only Medicare benefits as they're established, and they can serve people who are dual eligibles. They can specialize in serving people who are dual eligibles, people who are in institutions, or people with severe or disabling chronic illnesses. And there's been a considerable growth in the number of these plans since they were authorized in 2003, and the big growth took place in 2006. And there are probably now almost 500 of these plans around the country. Several of them currently operating in Michigan, and you see the names there at the bottom. Several more have been approved for 2008. And what some states have done with these plans, they cover all the Medicare services for dual eligibles. Some states have contracted with them to also cover Medicaid services, and there aren't very many Medicaid services left for dual eligibles with the movement of prescription drugs over to the Medicare side in 2006. So on the acute care side, it's just services like vision and dental and transportation that Medicaid may cover more generously than Medicare does, and also the cost sharing that low-income beneficiaries would otherwise pay in Medicare is actually by law, and it has been for years, paid for by Medicaid. and so some states will contract with these Medicare managed care organizations to cover that cost sharing as well, so providers don't have to separately bill the Medicaid agency for those cost sharing amounts. So that's been happening in a few states, and worth taking a look at a little bit further down the road, I think in Michigan. So just to summarize, managed long-term care, I think, does have major potential to improve care and to reduce costs over time. There are other states that have been doing this. They provide models and lessons for Michigan. These examples do exist in nature, and some of the problems have been worked through by these other states. For some of these states, the ultimate goal is really to fully integrate and coordinate both Medicaid and Medicare acute and long-term care services. Some states, Minnesota, Wisconsin, Massachusetts, Arizona, are doing this and have been doing it for a number of years, but it does take time to set up these kinds of integration efforts. And Medicaid-only managed long-term care can be a valuable step on its own merits, even if you don't necessarily plan to move right away to full integration of Medicare and Medicaid services. Just managing Medicaid long-term care